Hi, I'm Mike. Yes, I'm a paediatric haematologist working in Leeds Children's Hospital. I'm very aware that I probably know less about blood transfusion than everybody else on this call. So what I'll do, I'll talk about a patient who received blood, talk a bit about the disease that they had to require the blood transfusion, and talk about a complication of that transfusion. So you may not get to know much about more blood, but you'll get to know about the people who use the blood. So this is about a little girl, and she came to Leeds at the age of 11 years from Canada, but the family originally came from Nigeria. And she has a diagnosis of homozygous sickle cell disease, HBSS. And when we saw her in clinic, she was having various pains at home, sometimes losing some time from school, but generally okay. And she had been in fairly recently with a sickle chest crisis, which means the sickle cells were attacking her lungs and causing difficulty with breathing. And at that stage, she became anemic. Hemoglobin was 43 grams per litre. Her normal level is about 80. She had a reasonable reticulous account, but she had a top-up red cell transfusion and she got a bit better. And then ongoing from there, we saw her in outpatients. She was taking antibiotics, some folic acid to give her bone marrow some ingredients to make some more red cells. And we discussed this drug called hydroxycarbamide. And when we saw her, the family requested referral to the stem cell transplant team. So what's all that about? So sickle cell disease. So a bit of a break from blood transfusion. This is about the disorder of sickle cell disease. We think is probably the most common genetic condition in the UK, although people say hemochromatosis may be more common, but certainly is the most common genetic condition worldwide. And it's inherited in an autosomal recessive fashion, which means both parents have to have one gene to pass on two genes in total to their affected child. And both parents, therefore, are carriers or have sickle cell trait, and they are generally asymptomatic. But 1 in 2,000 of the population in the UK have sickle cell disease, and a load of children are born around the world with this disorder. And the projection is that up to 400,000 children per year will be born with sickle cell disease by 2050. It's got a very ethnic restricted instance, so it affects African, people from the Mediterranean, Middle East, Asia, and India. And how you survive or how you have a quality of life is mostly determined currently by where you live. And so if you live in a poor country rather than a well-financed country, unfortunately, the outcome for children with sickle cell disease is far poorer. So some estimates in Nigeria say that almost half the children under 5 years will die of sickle cell disease, whereas in the UK, less than 1% of such children die. So a huge inequality around the world with this disorder. And if you look at the total life expectancy, there aren't many data around, but even in the US, life expectancy is probably 2 decades shorter if you have sickle cell disease compared to a matched control population. So why does it happen where it does? Well, the sort of areas with the kind of orangey, reddish kind of areas are where sickle cell disease predominates. And that all happens because it's protective against malaria. And that's where malaria is. And if you have sickle cell trait, that means you have a reduced ability of malaria parasites to invade the red cells, which is protective and therefore leads to better survival. However, if you have sickle cell disease, the homozygous state, you have a much poorer outcome if you have malaria. But the overall balance for evolution is that it is an enhancement to have sickle cell trait in malaria endemic areas. So how does sickle cell disease present? Well, it's a multi-system disorder. It can affect from the top of the body down. You can get strokes. You can have children functioning poorly in school. It can affect the eyes. You can get a degree of heart failure. You can get difficulty breathing because of chest crisis. The spleen can be large and chew up your red cells, or can be very small and increase your risk of infection. You can get gallstones. Kidneys can be harmed. The bone marrow may expand and cause problems with bone strength. You can get osteomyelitis, you can get ulcers. Small children sometimes get swelling of the fingers and toes called dactylitis. But all this is down to vaso-occlusion. And the normal way we see children with sickle cell disease presenting is with pain. And the pain they get is bad pain, is pain that is analogous to pain you have in labor. And when children come into hospital, they need morphine, strong painkillers. It's a really nasty pain. And many children live with a bit of pain almost every day of their life, but come into hospital at extreme periods of crisis because of pain. So it's a very nasty disease. And as you can see, it causes life-limiting conclusions. So it's all down to a single gene change, this adenine to thymine, causing a single change in the amino acids that makes the way the hemoglobin function in low oxygen intensities change. So instead of being nice and flexible, the HBS will polymerize and cause like a structure. And so here it is causing like a structure, which is like a tent pole. So instead of having a round red cell, the tent pole pulls the sickle cell into funny shape. Slightly funny shaped tent, admittedly, but nevertheless, that's the kind of idea. And in simplistic terms, it's thought that these sickle cells get stuck in the blood vessels as they circulate to the tissues of the body, including lungs, bone, brain, and everywhere else. But it's more complicated than that, because when the sickle cells do get activated, they release their hemoglobin S. That causes inflammatory response, causes change in nitric oxide, changes the way the blood vessel walls respond. So it's a multifactorial process that leads to the vaso-occlusion, which is basically not getting enough oxygen to where it needs to be. So when we see children in clinic, we do simple things like saying, keep warm in winter, make sure you take a water bottle to school, take penicillin because of the risk of infection, and that's down to the spleen not working properly. We ensure they have immunizations, again, to stop the bugs that we worry about because of the spleen not working properly. Give folic acid to make sure they don't have a megaloblastic anemia. Make sure they know who to ring if they have a problem with pain or anything else, and give them as much support as they can in a multidisciplinary way. So the main treatment we give apart from that is this drug called hydroxycarbamide. And this is a drug that is still used in older populations with myeloproliferative disorders. So when the bone marrow is working too hard to make too many platelets or white cells or red cells. And that's very effective in those patients. It reduces the red cell count, reduces the platelet count, reduces the white cell count. And it was also noted that if it increased the proportion of hemoglobin F, fetal hemoglobin, in the red cell precursors. And some bright spark thought, well, those are quite good things for patients with sickle cell disease as well. So why not try hydroxycarbamide in patients who have sickle cell disease? And so this was tried in adults who had severe sickle cell disease, and it was found that hydroxycarbamide improved their outcomes. So then the same thing was tried in children in a study called Baby Hug, great name for a great study. And the placebo is the blue line, and the red is the hydroxycarbamide line. And the top is acute chest syndrome, pain, dactylitis, which is the swollen fingers, and need for transfusion. And you can see there's a statistically significant advantage to use of using hydroxycarbamide on all these parameters. And we now basically try and have all our patients on hydroxycarbamide if the parents will agree and they can tolerate the treatment. So that's a bit of background to sickle cell disease. And this is what this little girl was facing. So fast forwarding now to a couple of years ago. So she still had painful crises at home, despite using hydroxycarbamide. And in November of that year, she came in with leg pain, felt a bit dizzy on standing. So we felt, this probably does require blood transfusion because her hemoglobin was only 42. As I said before, her baseline is about 80, and her retic count was healthy, but still not adequate to maintain her hemoglobin in its optimal level. So she had a single red cell transfusion as a top-up, improved her HB, and off she went home. And chatting to the parents, because she wasn't doing that well on hydroxycarbamide, they would be interested in starting on a regular red cell transfusion program, ideally a red cell exchange transfusion. But later on that month, she came back in with more pain. And this is a chart of her hemoglobin. The firm blue line is the hemoglobin level. And the date at the bottom, the hemoglobin concentration here. And you can see her baseline hemoglobin is around about the 80 mark. So first admission, came in with her HB of 43, had a transfusion, came back in again, had a blood transfusion, but this time, instead of rising, her hemoglobin dropped. She had a reduction in her reticulocyte count. Hemoglobin S percentage increased. The LDH, or lactate dehydrogenase, is a marker of hemolysis, and that was very elevated. Although it is usually elevated in sickle cell disease, this was higher than her normal baseline level, and a Coombs test became positive. And this made us think this probably is hyperhemolysis. Now, we normally see hyperhemolysis about a week or 2 weeks or 3 weeks after the initial transfusion. So maybe here we are seeing the effects of the transfusion here, as opposed to the immediate effect of the transfusion given during this admission. So I'll come on to this in a second, but clearly this is a serious disorder, because if you give more blood, you can exacerbate the condition, and it can therefore drop the hemoglobin even further. But if you don't transfuse, you worry about very significant anemia, sometimes causing significant hypotension and sometimes complications, including death. So it's a double-edged sword. You want to give blood because a patient is unwell, but you can't give blood because that could make things more difficult. So you always phone a friend in these situations, and it's agreed that this probably was hyperhemolysis. So we gave a treatment with intravenous immunoglobulin, corticosteroids, and watched and worried. And fortunately, she slowly stabilized and got better, and then returned to her baseline hemoglobin over here. So hyperhemolysis syndrome, so what is it? Well, it's a form of delayed hemolytic transfusion reaction. But in this situation, you don't only destroy your donor cells, you also destroy your own recipient cells. And as I say, it usually reflects the transfusion over the last 2 to 3 weeks, essentially. And you tend to see a hemoglobin following transfusion that is lower than the pre-transfusion hemoglobin. You see elements of hemolysis. Your reticulocytes, the young red cells, can either become very low indeed, but certainly are reduced. And your normal hemoglobin A percentage tends to drop. And it reflects the activation of both the classical and alternate complement cascades. So there was a systematic review done by these co-workers last year, and they found a few studies, 51 patients, 31 with sickle cell disease, 12 with thalassemia. They found that the median nadir was 39 grams per litre at a median of 10 days post-transfusion, which is not particularly different to our patient. Many had positive antibody screens, but many had negative antibody screens. Some found new antibodies, but the majority didn't find new antibodies. And the majority had a positive DHET, but a significant number had a negative DHET. And looking at the literature, these are the treatments they were given. So recombinant erythropoietin, that's the hormone that drives erythropoiesis, and the aim is to push up your endogenous red cell production as much as possible. And to allow that to happen, people give intravenous iron as well, just to make sure you're not iron deficient. Standard therapies, though, are high-dose steroids and significant doses of immunoglobulin. Immunoglobulin, as you all know, is derived from blood donors. Concoction of immunoglobulins in a bottle, and it is aiming to try and reduce the effect of the immune system in a global way. But the effective treatments for this particular condition work on complement, And eculizumab is a specific inhibitor of complement, and tocilizumab is a drug used to inhibit IL-6 and macrophages. We tend to use eculizumab first. Tocilizumab is only used in significant events. And rituximab is an anti-CD20 antibody that inhibits the production of antibodies. So this isn't particularly helpful in treating the acute stage, but it may be useful in trying to deplete antibody concentration to prevent repetition of the hyperhemolysis at future exposure to red cells. So these are treatments that are recommended in the guidelines, which we just talked about. And obviously, ideally, you want to avoid red cell sensitization too. Because this is a rare and challenging condition, and the use of eculizumab is used in exceptional circumstances, all patients in England who have reported to have this condition, we report them to the UK National Hemoglobinopathy Panel, which is a panel of experts that meets monthly to discuss particular complications of sickle cell disease. So it just notes how exceptional this circumstance is really. And how do you prevent it? Well, it sounds like quite a few of the antibodies are down to rhesus grouping. So more detailed rhesus analysis would be helpful, allowing better matching, and maybe genotype matching, which we're trying to roll out for all the hemoglobinopathy patients in the UK. It may be something that we can do that will achieve a reduction in the instance of this condition. So you may think I'm not a big fan of red cell transfusions, and so I'm not really. And I always think the safest transfusion is the one that's not given. And especially when you have a circumstance like we've just described, you think, crumbs, can we really get away with transfusion? If we can, we should do. But sometimes we really need blood. It can be life-saving, as you all know, and can certainly be the case in sickle cell disease. So acute transfusions, we would use them in acute anemia. Sometimes you have a hypoplastic scenario after parvovirus infection where the bone marrow just turns off red cell production and you have to transfuse red cells. Similarly, if you have a very large spleen or a big liver, which form like buckets where all red cells go, you become very depleted in the intravascular compartment, you have to give an acute transfusion. Sometimes the sickling process is so acute that you're in a situation where you have to stop it, otherwise you're in a life-threatening situation, and that can occur if you have an acute chest syndrome, if you have a stroke, if you have multi-organ failure, if you've got a really tough acute presentation that's just not getting better with pain, for instance, we sometimes transfuse then. And if patients need surgery to prevent a crisis, they need to reduce their S level, and they have transfusion either top-up or exchange beforehand. Long-term transfusion program, we would consider doing this for patients thought to be at risk of stroke. It reduces the risk of stroke from 10% to 1% in those cases who are high risk. If, as you've heard, we're considering this patient who didn't get better on hydroxycarbamide therapy, or we have progressive organ failure, usually in adults. And we either top up with iron chelation, or ideally we undertake a automated red cell exchange, very, very rarely a manual exchange. And hats off to Taz looking after our patients so well in Leeds in this regard. So back to our patient. So how did she get on? Well, she survived the hyperhemolysis. She then went on to an allogeneic stem cell transplant from two separate donors. The first donor, the graft was rejected. The second donor was her father, who it eventually engrafted after a top-up infusion of his stem cells. And again, you know, the NHSBT in Barnsley were completely vital in getting the right stem cells for this patient. So MBS is involved in lots of different ways in a great way. And so she's now 2 years down the line from transfusion, pretty well. She's in school, she's functioning pretty well. She has, however, got ovarian failure, and she has got a degree of difficulty in concentrating in school. So even these curative options don't necessarily take a patient back to baseline. But on the whole, when you speak to children and young adults and ask them how they feel following the transplant, even if they have got significant sequelae to the transplant, they are far, far, far preferably in that situation than not having had a transplant and having the sickle cell disease. And you may ask, well, how come we got through the transplant without her hemolysis returning? Well, we exchanged her with red cells to reduce the risk of crisis in the transplant, but did so at the same time that she had her immunotherapy and suppressive treatments to prepare her for a transplant. Unfortunately, she got away without any further hyperemolysis.